Okay, I think we can start now. Hello, everyone. I would like to begin by acknowledging that the land on which we gather is the traditional and unceded territory of the Algonquin Nation. My name is Joanna Pizzullo, and I am the Director of the Mental Health and Wellbeing Research and Training Hub, also known as MeWeRTH, here at Carleton University. On behalf of MeWeRTH and the Department of Psychology, I would like to welcome all of you to our Let's Talk lecture. The Let's Talk lecture was created to raise awareness and combat stigma around mental health and topics that may not be talked about. Using a research lens, we hope to highlight the latest evidence for these often not talked about topics. Before we start the lecture, I would like to introduce Dr. Pauline Rankin, Dean of the Faculty of Arts and Social Sciences, for some opening remarks.
Good afternoon, and thanks, Joanna. What a pleasure it is to open this year's Let's Talk event, and thanks for the invitation. I was reflecting this morning on the power of the Let's Talk campaign, which essentially I think lies in the simplicity of the message. It's recognition of the healing that can be derived from the basic act of sharing one's thoughts and feelings, but also extending to others that most precious gift of listening. We know as vulnerable beings that talking and listening can be scary. It always comes with the risk of rejection or misunderstanding. But what this campaign reminds us of every year is that the benefit of engaging in conversations, either with large groups like this lecture, or even with one other person in a private moment, can be transformational and sometimes life-saving. So this message about the need for connection bears repeating annually. This year, in particular, as we take tentative steps to move forward from the pandemic, I think Let's Talk has a special resonance as we realize, perhaps as never before, that re-engaging our communication skills must be a priority. Let's be honest, many of us spent vast stretches of time over the past 3 years not talking. And the impact of those extended silences and the consequences of the accompanying isolation and loneliness now are evident in the explosion of mental health crises in our personal circles, our classrooms, and our communities. I'm very grateful for the leadership that the Department of Psychology and MeWeRTH in particular has shown in mobilizing researchers, staff, and students around mental health matters. The founding of MeWeRTH prior to the pandemic now seems prescient. I just checked my archived emails, and the first message I received about the idea for this research initiative was dated March 3rd, 2020. So Joanna Pizzullo may not only be a superb researcher, she may be psychic. I am not sure. In any event, MeWeRTH's central role in mounting an impressive array of important research and outreach activities around mental health at Carleton is both necessary and deeply appreciated. I'm always grateful to be invited to these events, particularly this lecture series, which prioritizes providing an evidence-based lens to subjects that often don't receive the attention they warrant. My thanks to the organizers of the event, and the warmest of welcome to everyone, especially our distinguished keynote speaker, whose remark I know we all anticipate with interest.
Thank you so much, Franklin. Great to have you with us. I will now turn it over to Dr. Michael Wall, who is a professor in the Department of Psychology, who will introduce our speaker.
Thank you very much, and good afternoon, everyone. Welcome to the MeWeRTH Let's Talk lecture on this snowy day. Although another name for this lecture could be the prodigal son of returns. As many of you know, Andrew was a master's student in the Department of Psychology at Carleton University several years ago. In fact, just before we logged on, Andrew and I were trying to figure out exactly how long ago it was. It was at least a decade ago, but who's counting? During his time here, he stood out as a dedicated and hardworking student. And I had the pleasure of serving as his MA advisor. But I must say, I use the term advisor here loosely. Even as a first-year MA student, it was apparent that Andrew was very special. And I think I learned much more from him over the years than he learned from me. After Andrew completed his MA, he moved on to the University of Calgary to complete his PhD in clinical psychology. and he is now a professor at Toronto Metropolitan University. He's truly come a long way since his beginnings here at Carleton. And like his hometown compatriot Drake has said, started from the bottom and now he's here. He's established himself as a leading researcher in the field of gambling studies and addiction in general. In fact, in just a very short period of time, he's become a prominent name in research on addiction and co-occurring mental health, the topic he will be discussing here today. Remarkably, Andrew has already published approximately 90 peer-reviewed papers, has secured 20 research grants worth over $1 million, has been cited close to 2,000 times, has an H index of 23. And oh, by the way, did I say that he got his PhD in 2020? On a personal note, I'm glad that I can call Andrew a friend. He is kind, he is generous, he is wicked smart, he's funny, and he's a good human being. But with all of this high praise and the current clamor about ChatGPT, I have to tell you that I did ask ChatGPT, who is Andrew Kim, researcher at Toronto Metropolitan University? And it replied, and I quote, "I apologize, I'm not aware of a Dr. Andrew Kim who's a psychologist. It is possible that Dr. Andrew Kim is not well known. Could you please provide more context and detail about him?" So in conclusion, I'm thrilled to introduce to you our distinguished guest speaker. Let's give a round of virtual applause to Dr. Andrew Kim for proving that starting from the bottom is not a limitation, but rather a motivation to achieve great things. And someday that will include being known by ChatGPT. Over to you, Andrew.
Thank you for that wonderful introduction, Michael. And, maybe it's because I use my Korean name when I publish, so perhaps ChatGPT will recognize Hyun-Soo Kim. But I am really, really happy, honored, and thrilled to be giving this keynote talk. As Michael, Dr. Wu mentioned, I started my graduate studies at Carleton University, and I really appreciate all the training that I got. When I was accepted, I really didn't have any research experience besides an honors thesis. I think Michael took sort of a chance on me and really instilled my passion for research. And so I'm really honored and happy to be talking about another passion of mine, which is the understanding addictions and co-occurring mental health. And this is through concurrent disorders. It's my latest line of research, and it kind of combines both my clinical interest and my research interest. And so I'm hoping to really give an overview of why concurrent disorders matters, why we should talk about it, and what can we do to better understand and, more importantly, improve the lives of those that have both an addiction and a mental health. So before I go through an outline, I just want to start off with a reflection exercise. So I want you to think about someone who might have a problem with alcohol, right? It could be someone you know, it could be someone you worked with, or generally speaking, what comes to mind when you think of someone that has an alcohol use disorder? So what might be going on at a neurobiological level? Think about what was their childhood like? What is their current life situation? What's maintaining the drinking despite the harms? What treatment strategies, medications would you use? What's their mental health like? And now, if you're like most people, some of the most common answers might be things like, in terms of neurobiological level, that there might be a dysregulation in the dopamine reward system. They may already been vulnerable with family history of alcohol problems. Childhood, you might think it might be one that was full of adversity, current life situation, there might be psychosocial stressors, food insecurity, lack of housing, unemployment. What's maintaining the drinking despite the harms might be compulsivity, lack of alternate healthy coping mechanisms, treatment strategies, CBT, motivational interviewing, 12 steps. And their mental health, you might think they may be experiencing distress, whether it's depression or anxiety. And now I want you to think about whether your answers to any of these questions would change if I were to ask you to think about someone who has a gambling problem. Right? Most likely not. And that's one of the things that I'm hoping to communicate with this talk is the benefits of understanding not only addictions, but mental health through a transdiagnostic or a process-based approach. And we'll get into what I mean by transdiagnostic and process-based. So I just have an outline of the talk. First, I just want to provide an overview of concurrent disorders, what it is, prevalence, and why it matters. And then the benefits of understanding concurrent disorders through a transdiagnostic and process-based lens. Here, I will provide an overview of what this is, how this conceptualizes addictions and mental health, and some of the research that I've been doing at Toronto Metropolitan University at the Addictions and Mental Health Lab to examine or provide empirical evidence for a transdiagnostic approach. Then talk about the role of addiction as a coping mechanism in mental health. And here I'll get into my clinical experiences, what I've seen, what clients, patients have told me, and some of the research we're doing now to examine coping, addiction, and mental health. And lastly, I will end with a discussion on potential clinical and treatment implications and future directions. So what is concurrent disorders? Well, simply put, concurrent disorders is when someone experiences both an addiction and a mental health concern at the same time. Now, concurrent disorders are also sometimes known as dual diagnosis in the States, but in Canada, dual diagnosis generally refers to an individual who may be experiencing a developmental disability and a mental health. In Canada, the co-occurrence of addictions and mental health we call concurrent disorders. It's sometimes called comorbid disorders as well, or co-occurring disorders. But really, it's the presence of an addiction, alcohol, cannabis, cocaine, gambling, gaming, and a mental health, depression, anxiety, psychosis. And why does concurrent disorders matter? Well, because what I want to try to get across is that addictions and mental health, they tend to go hand in hand. There is a strong relationship between the two. In the literature, what we see is that individuals with a substance use disorder are 2 to 3 times more likely to have a concurrent mental health disorder. So the presence of an addiction significantly increases the risk that an individual will also experience mental health. On the flip side, individuals with mental health are 2 times more likely to have a concurrent addiction. And again, if you have or if someone is experiencing a mental health disorder, it increases the risk of a concurrent addiction by 2-fold. And although it's hard to find exact prevalence rates of concurrent disorders, they've been estimated to be about 20 to 50%. And so lifetime prevalence of concurrent disorders at 20 to 15%. The best Canadian statistics I've been able to find is that 1.2 million Canadians are currently experiencing a concurrent disorder, meaning they're both experiencing an addiction and a mental health. This data comes from the United States, from SAMHSA, and they looked at, again, the co-occurrence of an addictions and mental health. And they looked at different types of substances and whether the individual who has a disorder with a illicit drugs, cannabis, opioid misuse, etc., also experience any mental illness or significant serious mental illness. Now, serious mental illness, they defined as psychosis, borderline personality disorder, bipolar disorder, whereas any mental illness, anxiety, depression, ADHD. And what this graph clearly shows is that there really is not a lot of instances when an individual who uses illicit drugs or has a substance use disorder only has that disorder. So if we look at illicit drugs here, only 15.7% of individuals, right, has just a substance use disorder, whereas 36.7% has a co-occurring or concurrent mental illness, and 50% has a concurrent serious mental illness. Put that together, 85% of individuals who has a substance use disorder also has a mental illness of some sort. Same thing for cannabis, same thing for opioid misuse, same thing for prescription pain relievers and heroin. And so addictions and mental health tend to go hand in hand. Alarmingly, the prevalence of co-occurring disorders or concurrent disorders, it's increasing. From 2009 to 2019, there's been a 73% increase in the presence of concurrent disorders. Now, this is American data, and I would also say it's likely an underestimation of the prevalence of concurrent disorders for two reasons. One, this data only considers substance use and not behavioral addictions, which I'll get into in a little bit later. And two, the data only covered 2019. And we know in the past 3 years, there has been a significant increase in addictions and mental health as a result of the COVID-19 pandemic. And so the rates and the increase of concurrent disorders is likely much higher than this data is showing. Now, as I mentioned, a lot of the data that we have on concurrent disorders come from the United States, and we don't have a lot of data in terms of concurrent disorders within a Canadian context. So one of the first studies that we looked at was to examine within a Canadian context, do addictions and mental health go hand in hand? What's the prevalence, or what are the rates? And what are some of risk factors that someone will present with both an addiction and mental health? So we recently published a fairly large-scale study that's looking at this, and it consisted of predominantly a sample of Canadian adults. And we wanted to examine the profiles of people that engage in addictive behaviors and maybe also experiencing the mental health. And so explore the patterns of addictive behaviors and mental health among people who aren't seeking treatment. And we had two fairly distinct samples. We had over 1,600 undergraduate students that were recruited from 5 universities across Canada. So we had students from Toronto Metropolitan University, students from York University, students from Mount St. Vincent, which is in Halifax, students from University of Manitoba, and from the University of Calgary. So undergraduate students all across Canada, as well as 600 adults that were predominantly about 95% that were residing in Canada, and the rest were residing in the United States. And one thing that I would like to highlight here is that there are significant differences between the two samples, and this is going to be sort of interesting and fascinating when we get to the results. But these two different demographic samples are fairly different. Mean age of the student sample was 20 compared to 30 in the community, and that was a significant difference. More men in the community sample compared to having more women in the student samples, and there was more, a higher proportion of people identified as Black, Indigenous, people of color in the student sample compared to the community sample. And we see a significant demographic difference across most variables. education, income, relationship status, etc. So quite two distinct samples. And what we wanted to do is to identify similar groups, so distinct groups that are all homogeneous. So 3 distinct groups, but the groups being more or less the same. And we conducted a online survey. We assessed people for their mental health. So we asked about their symptoms of anxiety, their symptoms of depression, symptoms of attention deficit hyperactivity disorder, substance use and addictive behaviors. So we had a variety of substances: alcohol, cannabis, vaping, cocaine, addictive behaviors, so behavioral addictions, gaming, gambling, sex, shopping. And we wanted to see, are there distinct but similar within the clusters or groups from these 3 variables, so addictions and mental health. And then we wanted to identify what differentiates these 3 groups. So it's more of an exploratory analysis. It's very data driven. And so why that's interesting and important is because then these clusters of the same groups or the distinct groups may not replicate in other samples. But what we found, though, is that across both the student sample and the community samples, there were 3 distinct clusters. And now recall that these 2 samples differ significantly in age, gender, ethnicity, employment. Yet we're still finding there's 3 distinct groups that can be sort of pulled out based on the presence of addictions and mental health. And in both samples, the largest group we called normative, and normative isn't the best word, but essentially they are people that have low scores in addictions and mental health, meaning they're not reporting problems with either addiction or mental health. And in fact, their scores, their average scores, were all below the clinical cutoffs in these measures. The second largest group were characterized by elevated levels of behavioral addictions and elevated levels of mental distress, so anxiety, depression, and ADHD. And the last group, what really differentiated them was their elevated scores on substances, in particular vaping. And so we have the largest group being folks that are saying their mental health is fairly good and that they're not having problems in substance or behavioral addictions. Second largest, those who have elevated scores of behavioral addictions, such as gambling and gaming, and higher scores on mental health, so some elevated levels of mental distress, and a third group that has all 3. So this is a pretty busy graph, but what this is really showing are the 3 groups and their mean scores on these variables. And so we have in this light blue here, that's sort of the normative sample. So these are folks that aren't really reporting high levels in addictions or mental health. We have the blue, the yellow, which is the behavioral addictions and mental health. So you can see that their substance use scores in alcohol, cannabis is fairly low compared to those in the dark blue here, which have really elevated levels of substance use. But what I wanted to highlight here is that there were no groups that were differentiated or characterized by just substance use, just behavioral addictions, or just addictions in general, and only mental health. So what we're seeing is that these groups, the addiction, whether substance or behavioral, and mental health are really going hand in hand. They're really occurring together. We also then looked at how did these 3 groups differ based on psychological characteristics. So we looked at things like impulsivity, how especially affective impulsivity or emotional impulsivity, this is just people who have a tendency to act more impulsively under emotional distress. We looked at perceived social support, emotion dysregulation, which is when people have difficulties identifying and regulating negative or distressing emotions, and adverse childhood experiences and childhood trauma. And what was really interesting is that we measured more than these variables, but these 4 variables were consistently found to differ between the 3 groups. And while there were differences between the dark blue, so the one that characterized by all 3, and the group that's characterized by just elevated levels of behavioral addictions and mental health, the biggest differences were found between the normative group and the other 2 groups. So people who were characterized by high levels of behavioral addictions and mental health reported greater impulsivity than those with lower scores on those variables. They reported lower social support, more difficulties regulating emotions, and reported more difficulties with childhood trauma. And this was also the case for the group that had elevated scores of substance, behavioral, and mental health. And so what we're seeing is that addictions and mental health go hand in hand, and there are similar psychological processes or variables that may help to explain or partially explain the co-occurrence of addictions and mental health. So why does it matter? Why are we talking about concurrent disorders? And why am I spending an hour talking about the co-occurrence of addictions and mental health? Well, because although addictions and mental health go hand in hand, what is really of importance is that it's associated, the co-occurrence of addictions and mental health are associated with a whole host of aversive outcomes. Yet, they really remain an underserved population. There's not much evidence-based treatments or access for people who experience both addictions and mental health. In terms of adverse outcomes, right? People with concurrent disorders compared to those with just an addiction or just a mental health concern, they're more likely to have increased hospitalization. There was a 15-year longitudinal study that compared individuals with schizophrenia with and without substance use, and those with substance use were 2 to 3 times more likely to be hospitalized. They have poor treatment outcomes. People with concurrent disorders, addictions, mental health, to those alone are likely to have increased dropout and do not as well in terms of their treatment response compared to those with just an addiction or mental health. Worse psychosocial functioning, right? People with both an addiction and mental health report they're more underemployed, they have more food insecurities, they have more financial insecurities. Individuals with concurrent disorders are much more likely to experience homelessness compared to an individual with an addiction but not mental health, and mental health and not an addiction. And they are more likely, they're at an increased risk of suicide. So individuals with borderline personality and alcohol are they're twice as more likely to commit suicide or attempt suicide than individuals with bipolar disorder, but not alcohol. And so the presence of addictions and mental health, although they go hand in hand, they're also associated with increased adverse outcomes. Yet the treatments for addictions and mental health I would argue, are lacking. It's come a long, long way, but the treatment for addictions, treatment for mental health still tend to be separated. They still tend to be siloed. I still often hear individuals who have said, I was turned away from this mental health treatment agency because they said I have to address my substance use first. I've also heard individuals saying, the substance use treatment center, they turn me away, say, I have to treat my mental health first. Yet, if substance use and mental health are related, where are people that are experiencing both supposed to go? And part of I would say, barriers for people to receive concurrent disorders care is that clinicians, healthcare professionals, feel like they don't have the competencies to work with people experiencing addiction, right? But I would argue is that there are some similarities. There are similar psychological mechanisms that are important to addictions and that can be treated as you would with mental health. In other words, the relationship between addictions and mental health can be conceptualized from a transdiagnostic perspective. And so before understanding or explaining concurrent disorders through a transdiagnostic lens, I think it'd be really helpful to apply this to addictive behaviors first. So we can conceptualize addictions and also to let you know what my views are of an addiction and how I conceptualize addictions, which is, of course, from a transdiagnostic lens, hence this talk. And why this is important is because the concept of addiction has significantly changed with the publication of the DSM-5, which now I think is about 10 years ago. So it's been a while. But when this was published, there was a whole shift in paradigm of what we believe to be an addiction. And so what was that change? Well, for the first time in psychiatric history, a behavior and not a psychoactive substance, so not alcohol, not cannabis, but a behavior, specifically gambling, was classified as an addiction. It moved from the impulse control section to substance use and other related disorders. And this shift occurred due to decades of research suggesting that gambling shared many similarities in terms of its cause, in terms of its risk factors, in terms of what's going on at the neurobiological or brain level, and clinical similarities, meaning the treatment strategies, to substance use disorders like alcohol and cannabis. In addition to gambling, a gaming disorder or internet gaming disorder, fancy word to say video game addiction, was included in Section 3 as a disorder that required a bit more empirical evidence to support its inclusion. Now, in addition to the DSM-5, which is used predominantly in North America, the ICD-11, which is another classification system of diagnostic disorders and used in Europe and lots of places around the world, included both gambling and gaming as a behavioral addiction. So again, now what we know as addiction is no longer just limited to psychoactive substances, but behaviors, things we do, can be classified as an addiction. Now, this has caused a bit of problems in a sense that it's sort of increased the number of addictions, and there's been something called a scope creep. So if behavior like gambling and gaming can be considered an addiction, what else is an addiction? And so I've seen things like Argentine tango, and these have been published in scientific journals. I've seen carrot addiction, fortune-telling addiction. And so it's been argued that if we expand the diagnostic borders, and there's a lot of controversy on why this is occurring, then we water down the concept of an addiction. Because what people are doing is they're really just looking at the symptom. They're really looking at the excessive behavior that's causing harms. So for example, they see someone who's going to Argentine tango 5 hours a day. They can't seem to stop going. Even when they try, they end up going dancing. It's causing problems at work. It's causing problems with family. What does that sound like? Well, kind of sounds like an addiction. And so they classify as an addiction just based on the symptoms and what they see. But going back to this transdiagnostic perspective, in other words, looking at addiction from sort of sharing similarities. When we look at evidence-based treatments for addictions, so alcohol, gambling, cannabis, video gaming, if we look under the hood of what these treatments do, the strategies are 95% similar. the evidence-based treatments for alcohol, cannabis, gambling, video game, cognitive behavioral therapy, motivational interviewing, right? The protocol does not change. Even 12-step programs, Alcoholics Anonymous, Gambling Anonymous, their 12 steps are identical. You can just switch the word alcohol for gambling, and it's essentially the same. And so treatments for addictions, whether it's substance or behavioral, tend to be quite similar. Now, this idea that the addictions are better conceptualized to be similar, the same and not different, isn't new. It's been around for at least 3 decades, if not longer. The similarity between even both substance and behavioral addictions has been proposed in different theories, unified theories of addictions. For example, Orford has this theory called the excessive appetites model, which they essentially outline primary and secondary psychological processes that lead to a strong attachment, think excessive engagement in various appetitive activities. Appetitive activity just means sort of like substance or behaviors. And Orford's model was one of the first to include actually substance and behaviors, right? Orford outlined things like alcohol, tobacco, cannabis, but also gambling, sex, shopping, food as potentially excessive appetites. And one of the psychological processes that Orford highlighted was that what these excessive appetites or addictions have in common is their ability to rapidly change our emotional experiences, right? This concept of mood modification, that whether it's food, whether it's gaming, whether it's alcohol, cannabis, it has the effect of shifting our emotional experience. Jacob's general theory of addictions was applying similarities between gambling and substance use. And Jacob also highlighted, one of the big similarities between what's common between all addictions is their power to manage negative affectivity. Fancy word saying again, addiction, substance or behavioral, has this power to shift our emotional states. The syndrome model of addiction, it is a etiological theory of addiction, essentially saying this is a theory that tries to explain what causes addiction, whether substance and behavioral. And according to the syndrome model, there are important genetic factors that are common to both alcohol, gambling, etc. There are similar psychological factors and there are similar social factors. An important psychological risk factor that is shared across addictions, according to according to Schaefer, is the presence of mental health. Again, addictions and mental health go hand in hand, and those who are experiencing mental health are at significant risk of developing an addiction compared to those who are not. Griffiths, fast forward moving along, Griffiths component model, again, trying to see what are similarities between all addictive behaviors. Griffiths noted salience, so that's sort of the preoccupation, needing to do it over and over again, can't stop thinking about it. Highlighted mood modification, ability again for addictive behaviors to alter our emotional states. Tolerance and withdrawal, where there's controversy whether tolerance and withdrawal can be applied to behavioral addictions. Some support, but not as strong as substance use, where there is this physiological change. Conflict, which is just impairments, and relapse, that addictions are characterized by periods of recovery and relapse. And then Hoffman and Hayes, the process-based approach is not unique to addiction, highlighted here because the process-based approach is essentially taking a transdiagnostic view or looking at the similarities across behaviors, but it applies it to not just addictions, but all psychopathology. So according to the transdiagnostic approach or process-based approach to psychopathology, it proposes that there's only a finite number of psychological processes that are shared across addictions and mental health, right? So substance use, of course, looks different from mental health, but what's underneath, what may be contributing to an individual who has an alcohol use disorder or depression, there's just a finite number of processes: behavioral, right? So perhaps withdrawing, motivation. So what are the motives? Emotional. Here they highlight emotion dysregulation, difficulties in regulating our moods, cognition, so unhelpful thinking styles, deficits in working memory, interpersonal and social supports. And according to this approach, this process-based or transdiagnostic approach, it divides risk factors into what are distal and proximal risk factors. And here they call it distal determinants. It's distal because it happened in time. And these distal risk factors include things like biological, social, and environment that interact with proximal, which are more closer in time to the expression of addictions and mental health. And these are psychological processes. So instead of seeing the average childhood experience of emotion dysregulation as distal, they're better conceptualized as proximal risk factors. So adverse emotion dysregulation, impulsivity interact with these distal determinants or risk factors to then influence whether an individual is going to experience addiction or mental health. And it further suggests that these proximal determinants mediate the relationship between distal determinants and mental health. Fancy word of saying that we know that genetic vulnerabilities, neurobiological deficit, childhood trauma are associated with the presence of an addiction, right? It's a robust finding, but it's really through its influence on these more proximal determinants or psychological risk factors that then trigger whether someone's going to experience an addiction or not. And I wanted to highlight some of the research that we're conducting in the ADMH lab that have tried to provide support for this transdiagnostic model to really examine whether it is really through these proximal determinants or psychological processes that these distal risk factors, biology, childhood trauma influences whether someone's going to experience a problem with an addiction. I'm not going to highlight everything, but I'm just going to highlight several studies. And this was a secondary analysis that we did using that same data set with the university students and community members. And we wanted to see whether this model holds for both substance and behavioral addictions. And here, the distal antecedent we're really interested in is childhood trauma, because childhood trauma has is a significant risk factor for addictions and mental health. It's a robust risk factor. And emotion dysregulation, this is the proximal risk factor that I think is of most interest to me in the lab. And that's for several reasons. One is because all the transdiagnostic theories of addiction postulate or highlight the potential for addictions to regulate our moods, shift in moods. And addictions are insidious in that it works, right? Addictive behaviors are powerful in that it has the ability to rapidly change how we are feeling. It works in the short term, but it's not helpful in the long term. And so we're really interested in this concept of emotion dysregulation or the difficulties in regulating our moods. So we tested whether childhood trauma was associated with addiction severity, both substance and behavioral, and whether this association can be accounted for by difficulties in regulating our moods. And it's also, there's robust findings to suggest that childhood trauma impacts our abilities to regulate our moods. Right, so childhood trauma can impact one's emotion dysregulation. So it was a cross-sectional survey. We measured childhood trauma using the adverse childhood experiences, which essentially asked whether people have experienced 10 different types of trauma, and you get a composite score, a total score ranging from 0 to 10, where 0 is reporting no childhood traumatic experiences, and 10 being the highest. Brief version of the difficulties in emotion regulation questionnaire. So with higher scores indicating more difficulties in regulating our emotions, And substance use, we use the brief screener for substance and behavioral addictions that measures 4 different substances and 6 different behaviors. And what we did here is we created 1 total score for all substances and 1 total score for all behaviors. And what we found here is support for this process-based transdiagnostic model. And these are all fancy numbers. So as Michael always says, I'm going to walk you through what this means, so don't focus too much on the numbers. But what we're seeing here is that both for substance use and addictive behaviors or behavioral addictions, increased childhood trauma. So the more childhood trauma you report experiencing is associated with greater problems with substances and behavioral addictions. More instances or experiences with childhood trauma, the greater inability or difficulties in regulating our emotions, right? For both the substance and behaviors, and emotion dysregulation, inability to difficulty in regulating our emotion, associated with increased substance use problems, increased behavioral addictions problems. And when you account for this relationship, this proximal or psychological process, this relationship between childhood trauma and substance use problems and behavioral addiction problems disappears. So it's really through emotion dysregulation that seems to influence the presence of an addiction. And we've demonstrated this sort of mediation pathway in a lot of other samples and a lot of other addictive behaviors. So we've looked at it in the context of problem gambling, as well as video gaming. And we've also looked at different distal antecedents, things like attachment, childhood attachment, and find support for gaming, texting, cannabis, and alcohol. So there seems to be this growing body of literature that supports this transdiagnostic view of shared risk factors, shared psychological processes. Now, I've always argued that this is, from a treatment perspective, fairly positive news, right? And I say that because as a clinician, I can't go back in time to prevent childhood trauma from occurring in our clients and our patients, right? It's static, it's happened. But what I can do is help people regulate their emotions. There are a lot of evidence-based strategies that help people regulate their emotional experiences. And we've also started to further investigate how these distal determinants interact with psychological processes to influence the expression of an addiction. So one of the more recent studies that's under review now is we again looked at the similar model with childhood trauma, cannabis use for this one, and difficulties regulating emotions. But we also then looked at the impact of negative and positive urgency, which is a facet of impulsivity. Negative and positive urgency is really essentially when people act more impulsively when they're experiencing either negative or positive emotions. For this, we had 586 Canadian students. Again, online cross-sectional survey, childhood trauma, same questionnaire as before. Emotion dysregulation, same questionnaire before. Substance use, same questionnaire before. And for impulsivity, we examined using the short UPPSP scale. It measures 5 different facets of impulsivity, which includes both the negative and positive urgency, sensation seeking, lack of premeditation, and perseverance. And I should note that we tested this model, whether this mediation model is influenced by impulsivity in all facets, but we only see the results, significant results for negative and positive urgency. So what does this really mean? And so here, again, we're seeing the same mediation pathway where negative urgency and positive urgency, that ACEs impact emotion dysregulation. ACEs impact cannabis use through emotion dysregulation, but it's only, that model only holds for those in moderate and high. So if you've experienced trauma and you have difficulties regulating your emotions, but you're less likely to act impulsively when you're feeling negative or positive emotions. Then it's increased chances that you'll experience problematic cannabis use. It's really among those who have difficulties regulating their emotions and are also higher in acting impulsively under those emotional experiences, where that's really seems to be a risk factor for developing problematic cannabis use. So what does this all mean? And as I mentioned, I'm really interested in the concept of emotion dysregulation, not only through my clinical experiences, but because a lot of the similarities or the theories of addictions really seem to highlight this component. And which got me to start viewing addictions as a potentially a coping mechanism for mental health. As I mentioned, addictions are insidious, right? The problem with addiction is that it works. It really does have an effect on regulating our emotions. It helps me escape from pain. I hear that a lot from our clients and our patients. So it really works from a short term, but it's got a lot of negative consequences for the long term. So when we talk about addictions or the relationship to addictions, mental health, there are generally 3 or 4 common theories regarding their interrelationships, right? So we have one that says substance use leads to mental health. And so an example of this is cannabis triggering the risk of psychosis, right? Or methamphetamines triggering the risk of psychotic break. Mental health to substance use, that it's really that mental health is a driver for increased substance use. And this is better known really as the self-medication hypothesis. We have a common factors model, meaning that there is this underlying third variable, and this could be childhood trauma that influences both mental health and substance use, or it could be those shared psychological processes, right? Things like difficulties regulating emotion, impulsivity that has an influence on both, and that they interact. There's a dual relationship that substance use impacts mental health, but vice versa, mental health impacts substance use. So it's that vicious cycle. And in terms of my clinical experience, my specialty is in concurrent disorder. So that's where all my clinical training has been. I worked at a specialized concurrent disorder center in Calgary when I was doing my PhD. I completed my residency at the Royal Ottawa, the Substance Use and Concurrent Disorders program, again, working with individuals that experience both. And so this is where my clinical experiences lie. And in working with individuals with concurrent disorders, the most frequent explanation I hear from patients when I ask them what was their cause of their addictions, and they often say, my mental health. I used it to cope with my trauma. I used it to cope because I was in so much pain. It made me feel numb. I could actually escape it. It's the only time where I can actually feel happy. And so you hear a lot of these stories about how substance use is a way for them to manage their negative emotions. Now, this is anecdotal evidence and clinical observation, which we know from the field may not be completely accurate. And so we conducted a series of studies to really examine this role of coping and understanding the expression of addictions mental health. So one of the first studies that we looked at that Dr. Nassim Tabri from Carleton is also involved in is looking at from people with lived experiences, that is those with lived experience, self-reported lived experience with addictions, what they think was the cause of their addiction, right? What do people that have experienced it, gone through, what do they tell us? And for this, we used a secondary analysis from the Quinte longitudinal study. Quinte is really just Belleville, so halfway between where I'm at and where I believe most of you are. And this study was actually about problem gambling. What happened was during that time, Belleville, Quinte area was thinking about opening up a casino. So they did a longitudinal study to look at, okay, what are the impacts of a casino in a community? Casino never got built, but the study occurred. And although the study focused on problem gambling, majority of the participants, so 75%, were recruited because they're representative of the Canadian population. And only 25% were recruited specifically because they're at risk of developing a gambling problem. And as part of this, they asked people who met threshold or cutoff for experiencing a problematic substance use, gambling, or video gaming, what they believe caused their addiction to gambling, their addiction to substance use, or addiction to video games. And so of these, we had 685 reported problematic gambling, 712 reported some problems with substance use, 75 reported problems with video gaming. And we then essentially took those, which resulted in 2,272 qualitative responses. And what we did is, using thematic content analysis, tried to boil down to common themes. The mean age of the sample here, 43.68 years, 43 years. Roughly equal split of women and men, but predominantly white. And what I would like to highlight here is that there were 10 unique categories, and there were differences in terms of the perceived causes, whether it was gambling, substance use, or video gaming. And so for addictive properties, not surprisingly, substance use, there's a lot more of that because of the psychoactive nature of it. For gambling, there's some of the enhancement. So risking money can be seen as exciting. Social determinants of health, a lot of folks said that they needed some money, they need to win some money. And what I would like to point your attention to is this coping, right? Coping was by far the most common response, and it accounted for about 40% of all responses. That when you ask someone what caused your gambling problem, what caused your substance use problem, what caused your video gaming problem, they said it was to cope with my distress. And here are some of those verbatim responses. The failing health and finally death of my wife. Childhood problems were unresolved. It eased the pain. To ease the pain, I became addicted. Anxiety and low self-esteem. Trying to escape the day-to-day realities. So it seems that, at least from the perspective of those with lived experience, that this ability to modify emotions is really powerful, and they contribute their problems with addictions to that. And so to support this, we're now starting to investigate with more of a quantitative or more of a statistical approach to see, do we see this happening as well? And one of the studies that we just finished, we're just collecting a little bit more sample, was to investigate the relationship, the role of coping in concurrent disorders in substance use and mental health. This, we have 311 post-secondary students for Toronto Metropolitan University. We asked them about their symptoms of depression, their symptoms of anxiety, and we also looked at alcohol use severity, alcohol use problems, cannabis use problems, and substance use motives. So what are the reasons for why you use alcohol, why you use cannabis? And the motives are organized into different reasons: enhancement, to feel good; social, because fun thing to do with my friends; conformity, everyone else is doing it; anxiety coping, so coping with anxiety symptoms; depression coping, coping with depression symptoms; boredom coping, coping with boredom. Now, we included all this into a model to see which of these motives may help to account for depression and anxiety and substance use. And so these are preliminary results, and we're just collecting a bit more sample. But what we're seeing is that of the motives that are significant for depression symptoms and coping, for depression symptoms and severity of alcohol use problems, they're saying they're motivated to cope with, they use it to cope with their depression. And that seems to be a risk factor for experiencing alcohol problems. Same thing for anxiety, they're motivated to drink to reduce their symptoms of anxiety. And for cannabis use, anxiety symptoms, there's boredom coping motives. So the sample sizes are a little small, especially for cannabis. So we're collecting more data to really see if these findings are robust. But what we're seeing a pattern here is that there seems to be this relationship where people are using addictions to cope with their mental health. And again, within a different sample, we looked at whether this relationship holds for concurrent psychosis and cannabis use, right? To see whether people are using cannabis and is that a risk factor of developing cannabis problems if they're really using it to cope with symptoms of psychosis. And just so quickly, what we're finding is that, again, we have this relationship where the coping modus seems to be associated with increasing the risk between negative symptom distress. So those are negative symptoms of psychosis like anhedonia, catatonia, lack of pleasure, as well as positive symptoms, things like hallucinations, delusions, etc. And so that brings me to the clinical and potential treatment implications. And so again, addictions and mental health go hand in hand. And there seems to be, at least for some, not all, but maybe for a lot, that addictions may be a way to manage their symptoms of mental health. So what does this mean for treatment? Well, it seems to suggest that what may be most effective is treating the underlying transdiagnostic or psychological processes that are common to both addictions and mental health. Now, I have a graph here, the component model of addiction treatment, and this was a model I developed in 2018 when I was at the University of Calgary. And this model was really trying to account for the similarities between substances and behavioral addictions. And part of why I wanted to develop a treatment model for behavioral addictions is because there's really isn't, with the exception of gambling, there really aren't any evidence-based treatments or resources to for people who are experiencing difficulties with, say, gaming, compulsive sexual behavior, to seek treatment. And yet from this diagnostic approach, well, you can capitalize on the similarities between substances and behavioral addictions, given that our treatment strategy should similarly work in similar ways. Right? But what you'll notice is that a lot of these components, call them components, think of them as psychological processes, are fairly similar to the process-based approach that have been proposed. Again, these psychological processes that are common to not just addictions, but also with mental health. And so if these processes, underlying psychological processes, are similar in terms of maintaining addictions and mental health, then it could be helpful to target that shared common factor. And in doing so, then you may be able to improve not only the addiction, but mental health. And in particular, one of the things that I think is really helpful is to help people find adaptive ways to cope with their distress, right? So not using addictive behaviors, but really treating or helping to develop skills in emotion regulation strategies. And now I'm mindful of the time, but I just want a brief note saying why this is helpful. So the other benefit, I would say, of using this transdiagnostic treatment approach is that it reduces the likelihood that someone may engage in addiction substitution. Addiction substitution is really when someone, let's say, for example, who recovers from substance use, say alcohol, then experiences a problem with another behavior, another addiction, in this instance, gambling. And so this was a research for my PhD dissertation where I really focused on understanding this concept. You hear a lot about it in clinical settings, but it's really not talked about in research. There really isn't as much empirical studies that I found that have looked at rates and the process of addiction substitution. So I won't get into huge details here, but conducted a systematic review of addiction substitution and found that a lot of studies about 1/5 of the studies found support for this concept, and that 7 to 90%, that range of people increasing substance use or other addictive behaviors range from 7 to 90. So there's a huge variance there. But what I found really striking and informative, or has potential implication, is that addiction substitution has significant impact on treatment outcomes. Consistently, those who engage, who jump from, say, alcohol to gambling, cannabis to sex, etc., have worse treatment outcomes. They're more likely to relapse, and they're more likely to develop a problem with another addiction. In terms of predictors, one of the most robust predictors that I want to highlight here is having a mental health disorder. And this sort of makes sense, right? If addictions are used as a way to cope with mental health, and you've only addressed the substance use or behavior, so you've helped someone reduce their drinking, you help someone avoid gambling, so they're no longer gambling, they're no longer drinking. But if you haven't addressed that function, or why is that someone drinking excessively in the first place? What is leading someone to develop gambling problem? If that's the mental health concern, or if that's depression, anxiety, and that's not addressed, then they're more likely to then develop a problem with another substance. Why? Because that substance has a similar function. It can also be used to modify our negative emotions. And just wanted to highlight, again, not going to go into a lot of details, but we looked at mixed method studies, so using both interviews and self-report questionnaires to examine the process of addiction substitution. And in terms of people who recovered from gambling, and they said they engaged in addiction substitution, the number one reason when we asked them, so why did you increase your alcohol use after recovering from gambling? It was as an alternative coping mechanism. It alleviated their boredom, it alleviated their negative affect, right? It was used to fill a void, right? I wasn't gambling, but I found the alcohol actually also helped me manage my depression, right? So, and you're more likely to engage in addiction substitution, again, if you only address that underlying symptom and you don't address the underlying psychological process, in this case, mental health. And we see this across the board in terms of when we look at the psychological processes, those who engaged in addiction substitution report greater family history of substance use. They report greater family history of mental health. So there is a genetic vulnerability that we're seeing here. They also report greater childhood trauma. So we're seeing these same distal determinants coming through that are being identified as important when we look at why and who engages in addiction substitution. Similar with emotion dysregulation, right? Those who engage in addiction substitution report greater difficulties regulating their emotion. And so they're using the secondary substance to manage their negative emotions. Then same thing here with impulsivity. Those who engage in addiction substitution report greater levels of impulsivity, specifically in regards to negative urgency. Again, that predisposition or increase of acting more impulsively under emotional distress. Okay, so then I just wanted to summarize, and I wanted to just note that, again, addictions and mental health disorders commonly co-occur. They really do go hand in hand. Of course, there are individuals who may just have a substance use or mental health, but generally speaking, they tend to share a lot of similarities, and the substance use significantly increases risk factor for mental health and vice versa. And what may help explain this high co-occurrence is sort of this process and transdiagnostic approach. Right, there are only a finite number of psychological processes, and these are common across addictions and mental health. The one that I've highlighted here is difficulties regulating emotional experiences. And of course, there are other risk factors like distal, but really it's through these psychological processes that really seem to influence whether someone experiences an addictions, mental health, or both. And in terms of a clinical implication, it's going to be helpful to address both, right? Especially in the context of addictions, we need to target the underlying psychological processes. What is driving that addictive behavior? What's that function of that addictive behavior? And from my clinical experience and the research that I'm exploring now, it really seems the driving factor is the ability for addictions, whether substance use or mental health, to regulate our emotions. It works in the short term, terrible for the long term, can lead to problems. So in terms of future directions, one of the things that we're working on now, we're about to launch a longitudinal research. So a lot of the studies I covered are cross-sectional, meaning that we only assess people's addictions to mental health at one time point. So we're about to launch a large longitudinal study that will follow people over for a year and assess various addictions to mental health and see how they are related, right? And that may help us gain more understanding whether is really one of the key factors that explains concurrent disorders is addictions as a way to cope with mental health. We're also investigating this transdiagnostic and process-based approach to addictions and mental health cross-culturally. So we have collaborations in Brazil, Korea, Gibraltar, Hungary, and Australia to see whether these finite psychological processes and what may be more important, what may drive addictions is culturally invariant. Fancy way of saying, do we see these across cultures? We're starting to empirically test the component model of addiction treatment. Fortunately, I wasn't able to highlight a preliminary study that looked at targeting working memory to reduce symptoms of not only psychosis, but problem gambling. And then if we find empirical support for the CMAT, then we expand it to concurrent disorders, right? Again, target those similar psychological processes, and can that be effective in helping with not only the addiction, but the co-occurring mental health concern as well. And I'm happy to answer any questions.
Thank you so much for this fascinating and enlightening talk. So we do have time for questions. If you want to ask a question, please put it in the Q&A and I will read it out for Dr. Andrew Kim. And maybe I'll get started with one while we're waiting for people to type it in. So I was wondering, have you ever seen any evidence that some combinations of addictions are particularly bad for people, like say gambling plus drinking is worse than gambling plus a sex addiction or something? Is there some addictions that are just together so much worse than their individual negative outcomes?
Wow, that's a really great question. And so you're referring to the concept of simultaneous use. And this is actually, I could have done a whole presentation on simultaneous use because it's one of my interests right now. But what we're seeing is that, so just to back up, there's concurrent use. So for example, concurrent use of gambling and alcohol is someone who gambles and drinks, right? So if I were to ask them, have you engaged in gambling activities in the past 12 months? Yes. Have you engaged in, have you drank in the past 12 months? They say yes. That would be concurrent use, right? But simultaneous use is differentiated if they said, I drink and gamble at the same time.
Oh, okay.
Right, so in terms of specific combinations, I think the research is in its infancy in terms of simultaneous use. There's a lot of research on concurrent substance use, concurrent substance use and gambling, but not as much research on simultaneous using. And I think that's a really important distinction. And a lot of the research that we are now publishing in our lab has shown that concurrent disorders is concurrent use is associated with a host of negative outcomes. Simultaneous use, much worse. And so I don't know if there's specific combinations, but if you engage in multiple substances or multiple addictions or combination at the same time, it's going to be associated with a host of negative outcomes compared to if you do both, but just not at the same time.
Fascinating. Thank you. So I have a number of questions here. I'm just going to go in order that they were posted. The first question is by Jennifer. Has there been much study of food addiction?
Yes, there's quite a bit. That's a really interesting one because with food addiction, there's a debate in terms of, it's a bit tricky to conceptualize because food addiction can be, some people argue that it's form of an eating disorder, like binge eating disorder. Some have suggested it is a substance use because of the processed sugar and the processed nature, while others argue it's a behavioral addiction. But if you conceptualize food addiction from a transdiagnostic perspective, then the substance use and the behavioral addiction really doesn't matter, because it's really the underlying addiction. Whether it's eating disorder or not, I think that's still up for debate. But there is quite a bit of research on food addiction, and they conceptualize it from an addiction perspective. And part of that is, again, that mood modification, right? I think there are a lot of people, myself included, that use food to regulate our emotions, right? So it's got that component. And there are studies saying food addiction is not, there are people who report food addiction, not eating disorders. And anecdotally, what we see is in treatment, if people are recovering from substance use or gambling, it's not uncommon to gain a lot of weight. Now, part of it is that when you're using substances, depending on the substance, your appetite decreases, right? So stopping the substance, your appetite increase. But I often also hear that actually, it actually helped me feel better. Like, I'm not gambling anymore. I'm still feeling distressed, so I just ate a tub of ice cream instead, right? So again, it's really talking about a similar function.
A question by Nicole. Can you please share the difference of negative and positive urgency?
Yeah, of course. So urgency is essentially a construct where we're acting more impulsively. So you're more impulsive when we're experiencing emotions. Negative urgency is when we act more impulsively when we're experiencing negative emotion. Positive urgency is we act more impulsively when we're experiencing positive emotions. So they're very similar constructs. And actually, in the past, that impulsivity scale used to just combine the two into an urgency. But they found through several studies, and when you do these fancy stats, that they really seem to be two separate factors, one for the negative emotions, one for the positive emotions. But in my research, we're seeing that it both has similar effects in terms of increasing the risk of addictions, both negative and positive. For in terms of positive, you can think of sort of like hypomanic and manic symptoms, right? When we're feeling really high, we tend to be more impulsive, and we know that's associated with substance use. So that might be accounting for it. So that's the difference.
By Stephanie, would you expect similar findings for adolescents? And are you planning any research with this age group?
That's a good question. And I would say yes. I study emerging adults, but not adolescents. I would imagine it's a similar psychological processes that are at play, but I think the addiction might differ, like the addictive behaviors. What we're finding really interesting is that rates of substance use tends to be decreasing. So there's this cohort effect, right? So people aren't smoking as much compared to, say, undergraduate students or adults 30 years ago, right? They're actually not gambling as much either. We're seeing a decrease in prevalence of gambling, but we're seeing an increase in other potentially addictive behaviors. Things like video gaming it's really increasing, especially in COVID-19. Vaping seems to be something that seems to be increasing quite a bit. But really, if we look at addictions and conceptualize from that mood modification similar perspective, then looking at the function, right? So even though the addiction might differ, the underlying processes, underlying reason why they may be excessively engaging or experiencing problems might be the same. And that could be that they're using it to regulate their emotions.
A question by Caroline. What if the addicted person does not recognize any childhood traumas or parental addictions?
Yeah, so that's only one risk factor, right? It's not a risk factor that's a necessity in terms of experiencing addiction. It's just one. We just know that it's a robust risk factor. But yeah, I've definitely worked with clients and patients who you would consider having a picturesque childhood, intact nucleus family, middle class, upper class, right? So it's only one risk factor of others that are potentially at play. So whether someone has experienced an addiction or not, it's quite complex. And I've often have patients and clients ask me, is my kid going to now be addicted because I am? And the answer to that is no, right? They're at risk, but it's not means that they're destined to become addicted. It's a piece of a more complex system, and they all interact.
I'm going to skip the next question for later because it'll be a nice finishing one. So let's take Elaine's question here. You mentioned that emotional regulation was a factor in both addiction and other mental health diagnoses. Were there particular emotions that were more challenging to regulate and more likely to be related to substance use? I'm thinking of guilt and shame, for example.
That is a very good question. And part of the research now, the state of literature is it's not very nuanced, right? We're just saying emotions and negative emotions. We're not really separating what negative emotion is. Is it boredom? Is it depression? Is it anxiety? And the longitudinal study that I mentioned actually has a measure of guilt and shame. Because, I think guilt and shame leads to distress and addictions as a way to cope. But there's not much nuances right now. So we're just really categorizing as just negative emotions. But that's a great question. And my thought is that we're going to find similar findings, that guilt and shame is going to be associated with addictions. Whether it's more difficult to regulate from a clinical perspective, regulating depression, they're interrelated, right? Guilt can then lead to feeling low mood or depression. So yeah, it's a good question.
So we have time for maybe one more question. So I'm going to take Sydney's here. So if you want to answer, she says, what led you to this career path and sparked your passion in this area? I have a really strong passion for addiction counseling and hope to get into a career where I can look at the combination of mental health and addiction and help people directly.
Yeah, and so the question to that is, in terms of addictions in general, I have a close family member that struggles with addiction. And growing up, I never understood why, right? And to be honest, understanding and studying addictions has made me look at them with much more compassion. And so that's how I generally got into addiction as well, just because I couldn't understand it. I thought it was a choice. Why can't they just stop, right? Like, can't they see it's harming everyone? Why do they keep doing it? So I couldn't understand the component, but studying it, it's complex. There's so much to it, right? Addiction isn't a choice. I mean, I would say I've had no patient come into my office when I ask them, what brought you here? I have no one that ever said, I wanted to become addicted and here it is, right? So that's how I got into it. In terms of gambling, I thought it was fascinating that, again, a behavior could be an addiction. So what really is an addiction? So what's the function of it? And if, again, studying gambling, I was very fortunate to study that with Michael, because then that really helped me try to understand how is gambling similar to alcohol, and then help to develop this program of research.
Thank you so much. So on behalf of MeWeRTH and the Psych Department, thank you, Dr. Andrew Kim, for this wonderful Let's Talk lecture. And thank you, everyone, for listening. And I wish you all a great rest of the day. Enjoy the fresh snow if you can, And thank you.